So that is her ardent, that's her ardent passion. And she has a very wide experience. She has 18 years of experience in nursing. And she's also a certified trainer by the NHSRC, that is the National Health System Resource Center. Okay. And she has also won the St. Christopher Hospice Award as a pioneer nurse in 2020. Over to you, Sister Sheeba. As Sheeba said, we'll just wait. Hopefully she gets her, it's all electronic glitch.
So true, ma'am. Today, even I am also facing the technical glitch. So, yes.
See, the thing is that this electronic and science is a double-edged one. Okay, we always have to see the positive in it. So we are all able to do these online sessions with the help of the Z world. Okay, so we'll bear with it and move forward. And yes, she's there, ready to go ahead. Yeah. Go ahead, Sister Sheeba. Nice to see you.
Thank you, ma'am. Nice to see you. Good evening to everyone. So as ma'am said, today we are going to learn about the wound management. So let me share my screen. So I hope my screen is visible to everyone.
Yes,
yes,
perfect and good.
So okay. So we all know that what is wound. We all are medical professionals. So you might have seen different types of wounds in your settings. So in palliative care, we have seen two different types of wounds. One is pressure ulcer and another one is fungating wound. So first, let's see what is pressure ulcer, and then we will discuss on fungating wound management. So we all know that pressure ulcer, it's very common in palliative care because most of the time we are seeing the most of the bed-bound patients. The bed-bound patients are the vulnerable groups for getting pressure ulcer because of the immobility. So there are three major causes of pressure ulcer. One is continuous pressure, and another one is friction. The third one is moisture. These are the three major causes of pressure ulcer. What is pressure ulcer? The pressure ulcer is a localized injury to the skin and other underlying tissue, usually over the bony prominence as a result of prolonged unrelieved pressure. So what happened if the patient is not able to move independently? What happened is the result of the chance of unrelieved pressure on the underlying tissue. If there is an unrelieved pressure on that underlying tissues, can cause localized injury, especially on the bony prominence, but it can occur anywhere. Okay. And coming to the pathophysiology, just imagine a patient lying on a bed. So because of the continuous pressure, the patient is not able to move independently. Because of the bone weight, that bone weight will be compressing the underlying tissues. So what happens if the tissues are not getting adequate blood supply? The tissues will, after a period of time, the blood vessels will collapse. And that leads to the tissues not getting adequate nutrition from the blood, and then tissue ischemia. Finally, stress and breakdown. This is the pathophysiology of pressure ulcer. Why I am telling this you all is, if we have seen bed-bound patients, definitely we should tell them how we can prevent pressure ulcer. If you keep it in mind, the pathophysiology, then you can explain well, and they will understand well, and they will take it as an important thing. Otherwise, they won't change the position 2 to 3 hours. So this is very, very important. How to tell them the pathophysiology of pressure ulcer formation. So coming to the risk factors, there are a lot of risk factors. The first one is friction, and the next one is shear. So this is the most common things, because of these are the extensive factors. So if you see the friction, bedbound patient, the caregiver need to, for a bedbound patient, the caregiver needs to change the bed sheets every day. So we have nurses. Nurses are trained to change the bedbound, the patient's sheets from a bedbound patients. They know very well, but the caregivers doesn't know. What happens when they go home? They uh, they pull the sheets under their patients. So that leads to friction. So sometimes if the frictions can cause shear that damage this thing, like a small peeling can happen. So friction. So we have to prevent that friction. So how we can prevent the friction? So before discharge the patient from the hospital, we have to empower the nurses to demonstrate them how to change the bedsheet for a bedbound patient. So that is about friction. The next thing is shear. So what is the shearing force? You can imagine an obese patient. So what happened when they, because of that obesity, there is a chance of slipping downwards. When we try to re back to their normal position, we usually call one or two members and pull the into the normal position, to them back to the normal position. What happened? We used to give more pressure on their body. So there is a chance of deep tissue injury. Okay, so that is that is also we need to prevent, because if the help of a sheets, so that will be helpful, because instead of that pulling the patient, you have to take a sheets, and then you can try to move the patient from downwards to upwards. And the next thing is inward sensory perception and inward physical mobility. So you can imagine a patient as a paraplegic patient. So they are not able to sense their lower part of the body. Even if they want to change the turn the position, change the position, they need to turn from supine position to side lying position. They won't, because of they are not able to lift their lower limbs. So that patients can get pressure ulcer easily, and that patient affected the involved physical mobility also. They physically they are not able to move independently, and altered level of consciousness, either semi-conscious or unconscious patients is the risk factor, this group of getting pressure ulcer. And the next one is fecal and urinary incontinence, moisture. So here, if the patient is having urinary or fecal incontinence, there is a chance of continuous wetting. No, so the patients will get pressure ulcer and malnutrition, dehydration. Even if you change the position every 2 to 3 hours and give special attention on that skin, if you are not giving proper diet to the patient, especially the lack of protein containing diet in their diet can cause pressure ulcer. So you have to make sure that whether the patient is taking adequate food intake, especially protein intake, and excessive body heat and advanced aging. These are the common risk factors of pressure ulcer formation. So let's see the common sites. Here you can imagine that you can see that picture. It can occur anywhere. Okay, even if the patient is in wheelchair, also the patients can get pressure ulcer, especially on the bony problems. But it can occur anywhere. So here you can see some images also. Heel, occiput, scapula, sacrum, toes also affected. So these are some pictures of different areas is affected with pressure ulcers. So coming to the common sites, supine position. This is the best position for usually the patient. This is the common position for everyone, especially patients. So even if the patient is on supine position, occiput, elbow, sacrum, heel, scapula, even toes is also affected with pressure ulcer. Why I am telling these pressure points is, so when we turn the patient from supine position to side lying position, you have to give special attention on these areas. Because if there is any color change there, we need to give a further prevention of further pressure on that area. Okay, so that is why If we identify earlier, we can prevent further deterioration. And the next position is side laying position, either right lateral position or left lateral position. The patients can get these sides pressure ulcer commonly. Here, ear, shoulder, elbow, knee, heel. So when the patient is in side laying position, one important point you have to keep it in mind, in between the knees. So always you have to keep a soft pillow or a folded sheets in between the knee. Otherwise, the knee is between the rubbing together, right? That can cause gain friction. There is a chance of peeling of skin in between the knees. So coming to the Fowler's position, this is we all know that this is the good position for controlling dyspnea, breathing difficulty patients can get his relief with this position. But even if the patient is in Fowler's position also, at least a 10-degree position change is mandatory. At least 10 degree. You should not give that supine position or side lying position to the patient, but you have to keep a 10-degree turn, either right side or left side. You have to give. And coming to the prone position, head, elbow, chest, reproductive organ, knee, toes. These are the common the points. Why this is one of the important position when we are planning to go for a surgery. For example, if the patient is having stage 3 or stage 4 pressure ulcer formation, that time we used to do, the patient is patient health condition is okay, then we refer the patient to the surgeon. If the surgeon prefer to do the skin grafting procedure, after the skin grafting procedure, they have to keep it in maintain this prone position at least 3 weeks. So before posting the patient to the procedure, that invasive procedure, the skin grafting procedure, we have to train the patient in prone position. If you train the patient in prone position, you have to keep it in mind. These are the important major points the patients can get pressure ulcer. So coming to the stages of wound. So there are, I think we all, how many stages are there? How many stages are there?
You can type in the chat. Someone has typed 4. So you can all type in the chat.
Okay. 4, 5, 4. 4. Okay, thank you for your contributions. Let's see one by one. So the stage 1 is non-blanchable erythema. So when we turn the patient from supine position to the side lying position, we have to check the skin always. If you have seen these kind of color change in that patient, you have to give apply your pressure, your finger pressure on that point, that area. So that redness remains there. If you apply finger pressure on that area, so the red color remains there. That is stage 1. That is called non-blanchable erythema. Okay. So we will discuss the management later. This is stage 1. So stage 2 is partial thickness or shallow open ulcer or damage that break into the dermis or serum filled blister. So this is the stage 2, partial thickness or dermis layer will be breakdown or blister formation. If the blister formation there, definitely the skin will damage. The blister will burst and the skin will open. Okay, so the dermis layer will be damaged in the second stage. The third stage is full thickness ulcer. All the small subcutaneous tissues will be affected. So sometimes tunneling will be there. So what is tunneling? A narrow opening or a passageway that can extend into any direction through the soft tissue. So why I am telling this tunneling is, this is very, very important. When we do the assessment of the wound, how to check whether the wound is having any tunneling or not. If the wound has any tunneling, you have to special attention on that area. If you don't give special attention on that area, your the wound won't heal properly. So you have to check whether the wound is having any tunneling or not. And coming to the stage 4, exposed to muscle, bone, and tendon. So this is the stage 4 pressure ulcer. We can able to see the muscle, bone, and tendon. And the fifth one is unstageable wound. So unstageable wound is, you can see there are black necrotic tissues on the top of the wound. We can't say this is this could be stage 4 or stage 3. So if there is a slump or eschar on the top, we can't assess the stage. That is called unstageable wound. When we unstageable wound. So when we document it, you have to document it is an unstageable wound. And the next one is deep tissue pressure injury. So as I discussed earlier, shearing force. So if you give a shearing force to the skin, so after maybe 1 week or 2 weeks, this kind of things will be there. Sometimes this kind of ulceration will be there. This is deep tissue pressure injury. So non-blanchable, deep, dark, red, purple, or maroon discoloration. Okay, so this is because of the shearing force. And sometimes it is a coming out of stage 3 or stage 4. So the tissue damage from inside to outside. So not inside that outside to inside. Okay, because the deep tissue injury can cause the tissues inside the tissues are damaged, and then finally the skin, the dermis layer will break down. So coming to the assessment part, so we have learned about 6 stages of wound. The first stage is non-blanchable erythema, and the second stage is partial thickness or dermis layer will be breakdown. The third stage is full thickness ulcer. The subcutaneous tissues will be affected, and the fourth stage is exposed to muscle, bone, and tendon. The fifth stage is unstageable wound, that is the black necrotic tissue on the top of the skin. We can't assess the stage, that is unstageable wound. The sixth one is deep tissue pressure injury. So coming to the assessment, always we should assess the patient skin in every visit, especially for a bedbound patient and the wheelchair patients. What are the things we should assess? Assess the pressure points. Okay, so you have to check whether there is any color change or not, and assess pain associated with it. If the patient is having wound, have to check whether the patient is having any pain or not, because this is we all know that pain is a subjective symptoms. You have to ask them whether the patient is having pain or not. So if they have pain, you have to give some analgesics for that, and make sure that the patient is having pain free, and then you can do the management part. Assess the location and measure width, length, and depth. Approximate measured width. You have to measure the approximate width, length, and depth. And stages of wound. We know that the stages of wound and presence of exudate. So exudate is oozing out of purulent discharge or water from the ooze, that discharge, or some watery contents from the wound. These kind of things we call it as exudate. You have to check for that, and then assess for tunneling. We learned about tunneling. You have to assess well, and all those details you have to document it well, because the next day we have, when we see these patients, you have to check whether the wound is healing or not? Is there any change or not? If your treatment is not good, you have to change the treatment also. So that is very, very important. And the another important thing is, if you have seen a patient with wound, next time your colleague will be seeing that patient. If you document it well, the colleague will understand everything from your documentation. And coming to the management, so as I said earlier, always medicate the patient pain before wound care. This is very, very important. You have to ask them whether the patient is having pain. You have to give something for pain, and then you have to do the the wound management. So coming to the stage 1 management, you have to teach the caregivers to turning techniques and excellent incontinence control. You have to prevent further pressure on that area. That is the management of stage 1. So this is non-blanchable erythema. There is no breakage, only redness will be there. So that time you have to prevent further pressure on that area. That is the management of stage 1. Coming to the stage 2, that is dermis laris damage, but there is no infection, only clean wound. So that time you can clean with normal saline. That cleaning of and dressing with normal saline is enough. So coming to the stage 3, 4, and unstageable and deep tissue injury, if slough is there, have to do the surgical debridement. Okay. And always you have to use normal saline for cleaning the wound. So you can train the patient about how to make homemade saline also. I'll come to that later. How to make homemade saline, I'll tell you. If there is an odor or infection, okay. So most of the time, this kind of wound here has that anaerobic bacterial infection. So metronidazole is a good medication for controlling anaerobic bacterial infection. So you can apply metronidazole. Take in the tab metronidazole, that is cheap also. You can take metronidazole tablet and crush it, make it a powdered form, and mix with the white petroleum jelly and apply on the wound. Okay. So here nowadays we know that literature says moisture is also one of the important factor for wound healing. So instead of dry powder application, you can make some, you can apply mixed with some white petroleum jelly, make it a the gel form and apply, so that the wound will get two effect. Metronidazole will control the infection, and the white petroleum jelly will give a moisturizing effect to the wound. And also you can apply debridase ointment and Megahil. So this is quite expensive. If the patient is affordable, you can suggest this. But sometimes our surgeon will suggest these kind of medications. So if we apply, if the surgeons suggest these kind of medications like debridase ointments for a slough removal. So after the slough removal, we used Megahil ointment. And then continue the management part, charcoal. So this is one of the good agent for controlling bad smell. Usually malodor is one of the major symptom here. So this is they won't be able to manage, because a lot of foul smell will be there, especially stage 4 and stage 3 and stage 4 pressure ulcer. So that time you can suggest charcoal dressing. Charcoal dressing is also available, but the thing is quite expensive. But you can see the charcoal pieces. This you can take 1 or 2 pieces and keep under the bed of the patient, or keep it in the corner of the room. So that will help to absorb the bad smell. And we don't use any hypochlorite solutions and like powder iodine and hydrogen peroxide to the wound, because these will destroy the granulation tissues. If there is a stage 4 pressure ulcer, sometimes the surgeon will suggest clean with powder iodine solution. That time we dilute with normal saline, and then we clean with powder iodine, diluted powder iodine solution. And after that, we again clean with normal saline, and then apply some medication on that area. And next, the management part is surgery consultation. If the patient's health condition is okay, then you can refer the patient to the surgeon and take their opinion also. So, as I discussed earlier, skin grafting procedure, if the patient is able to, if the patient is a good position to do the surgery, then you can do the skin grafting procedure based on the surgeon's opinion. And the finally, negative pressure wound therapy. This is the another way of management of pressure ulcer, especially stage 4. There are a lot of exudates will be there. This will help to absorb and remove the exudate from the wound, and also will give a continuous stimulation to the wound. This will help to improve the blood circulation and fast healing of the pressure ulcer. And coming to the homemade saline, so we always within the hospital we have nurse, and also we have normal saline bottle. We will use normal saline from the that bottle. So, but when they go back, sometimes they will buy it from the medical store. Sometimes the patient is not able to buy that normal saline. Then you can teach the patient about how to make a homemade saline. They can take 500 ml of water and add 1 teaspoon of salt, and then boil it, cool it, keep it covered. So that water is enough for wound cleaning. So this just yeah, that imagine this is this is not a surgical wound. This is a the pressure ulcer wound, and like fungating also, cancer wound also. So this won't need a clean saline. So the normal saline is clean. Clean saline is enough for wound cleaning. And also you have to teach some home made dressing supplies also. Here, just imagine a corona situation. We are not able to see the patients also. So that complete lockdown were there, no? So that time, if we teach the caregiver, sometimes if the usually the palliative care, most of the palliative care centers will be giving the dressings to the patients. But if it is finished, what is the local remedy? How to teach them? They can take a old cotton sarees or dhotis and cut them into squares and then steam them. Okay, half to 1 hour. So that is, and also if they want, they can apply white petroleum jelly on the top of the cotton clothes, and then they can steam it. So that will help to prevent the adherence of the wound also. So we all know that prevention is better than cure. Here also, always try to prevent pressure ulcer. If you have seen a bed-bound patients, always try to prevent pressure ulcer. You have to teach them and they educate them and demonstrate them how to what are the ways to prevent pressure ulcer formation. Here, position change every 2 to 3 hours. We have to change the position. For a wheelchair patients, at least 15 to 20 minutes, they need to relieve the pressure. And manage incontinence. Here, moisture. If they have a continuous moisture there, they can get pressure ulcer. Here, if the patient is having urinary incontinence, you can think about the catheterization, or if the patient is not willing to put a catheter, then you can think about the diaper application and frequent changing of linen also. Sometimes the patient is not affordable to buy the diaper, then you can teach them. They can use their own clothes, but if the linen wet, they have to remove it and replace it as soon as early as possible. That is very, very important. And special mattress, special surface like air mattress or water mattress, you can suggest. So, and also pillows and cushions. This will help to prevent that pressure on the bony prominence. And if you suggest a water mattress or air mattress to the patients, they might be thinking like, okay, this mattress take care of everything. After that, they will not change any position to the patient. So this can cause again pressure ulcer, because this is not 100% measure for preventing pressure ulcers. We know we don't have any evidence, but this will help to prevent pressure ulcer formation. But they have to change the position. If you continuously put the patient in same position, that patients will get pressure ulcer. And nutrition, hydration, exercise. This is very important. So lack of protein intake in their diet can cause pressure ulcer. So nutrition and hydration is also, you have to educate them and empower them, and exercise. So if you give a passive, if the patient is not able to do the exercise, you can educate the and empower the caregivers to do some passive exercise, because if you give some exercise to the patient, that will help to improve the circulation, and then that way we can able to prevent pressure ulcer formation. Always try to wrinkle free, give a wrinkle free bed to the patient, and cut short the nails. So this is also important. So all you can keep it in mind is a small tip, SKIN. So this is always you can keep it in mind. We don't you don't miss anything. Whenever you have seen a bed-bound patients, you have to think about SKIN. So these are the ways we can prevent pressure ulcer. What is first is supporting surface. You have to make sure that your patient is getting proper supporting surface. Okay, like air mattress or water mat, or air cushions or soft mattress, anything. You have to think about that first. And the next S is skin inspection. Whenever we turn the patient from one position to the another next position, like supine position to the sideline position, you have to check the bony prominence in skin very well, so that we can identify if there is any color change on the skin earlier. And keep moving, please keep moving. Every 2 to 3 hours, we have to change the position. Okay. And the another one is incontinence. Incontinence and moisture control is important. Bladder and bowel care. So as I discussed earlier, bowel care for incontinence, you can think about catheterization and frequent changing of that diaper or linen. And the final one is nutrition. Nutrition and hydration is also important. So these are the way we can able to prevent pressure ulcers. So how we can engage the patient and family? This is very important, because most of the time we used to use the term you. You should turn the patients. You should give some food. You should give some massage. You always be used to use the term you. So instead of you can think about to use the word we. So if we use the term we, they might be feeling like, okay, somebody's begging them to help them. Okay, they are not alone. So we always say it's like that. Okay, so without caregivers support, we can't do anything. We need that proper caregiver support, and we have to empower them. And without them, we can't do anything, because this patient is not in the hospital. The patient is after a period of time, we need to send them back to their home. So they are the person, the caregivers are the person to take care of the patient. So we have to respect them. So we start the word to, instead of you can start the use of your word we, so that time they feel more comfortable. And also we have to think about some the patient information leaflets. This is a Malayalam leaflet. So you can give these kind of leaflet to the caregivers side, so that if they have any doubts for changing the position or any things, they can go and look into that leaflets. This will helpful to the patient. So we have a small video on pressure ulcer prevention. Let's show that video. Thank you. I hope that video will is helpful to everyone. So that is the prevention of pressure ulcer formation, that video. Now we move on to the fungating mode or cancer mode. So let me ask one question. What are the major difference between the pressure ulcer and the cancer mode? Any answers?
Bleeding,
Bleeding. Okay.
pressure. Wait.
Pressure ulcer is preventable. Very good. Yes.
Pathophysiology of each are different.
Yeah.
Uh,
So, okay. Proliferative growth. Okay. So that is okay. Thank you. Thank you for your answers. Pressure ulcer, the major difference between pressure ulcer and cancer only is pressure ulcer is preventable and curable most of the time. This is not preventable and not curable. So this is the major difference between pressure ulcer and the cancer. So what is fungating wound? So fungating wound is a primary or secondary malignant growth in the skin which is ulcerated and difficult to heal. Okay, it's the same time the ulceration and proliferative growth will be there, and it look like a nodular fungus shape and the cauliflower shape. So because of that nodular fungus shape, because we used to call this kind of wound is fungating wound. This is not because of fungus. It look like a nodulous fungus shape. Okay, and also it's a cauliflower in shape also sometimes. So what is the pathophysiology of these wounds? Develop a non-tender skin nodules there initially, and gradually the skin nodules will enlarge, and based on that leads to disruption of capillaries and altered coagulation, finally tissue hypoxia and necrosis. This is the pathophysiology of the cancer. So I don't know how many of you heard about the Magdalene ulcer. This is one of the important point we have to learn today because the malignant developed from the chronic wound. Okay, so because burn scar ulcer, example, burn scar ulcer, pressure ulcer, venous leg ulcers, maybe that after a long period of time there is a chance of developing that malignant skin the cell into the wound. So that is Magdalene ulcer. That is the pathophysiology is little bit different. Appearance of mass in the wound, that is the initial stage. Onset of wound pain not previously present. Previously it was not pain, but gradually the patient, if this kind of cancer cell origin, the patients will feel pain and change in the character, volume and appearance of the drainage. So that time, if these kind of changes there, better you can refer the patient to the oncologist and make sure that whether the patient is having any Magdalene ulcer or not. Because this is a curable cancer. So if you have seen these kind of changes, better you can refer the patient to the oncologist and take a biopsy and make sure that whether there is any cancer or not. So coming to the problems, from the first day onwards, we were talking about palliative care. It's for patient and their family. This is a non-healing ulcer. This patient is having lot of problems. We also talked about the total care of patient. Here you can think about the physical problems, psychological problems, social problem, and spiritual problems. So what are the physical problems can occur? So here pain. So sometimes these kind of wounds patients can experience two different types of pain. One is nociceptive pain and neuropathic pain also. Because nociceptive pain because means direct exposure of dermis can cause that patients can experience nociceptive pain. Sometimes the tumor will compress the blood vessels. So that time the patients will get neuropathic pain. So, and these kind of things you have to check whether the patient is having neuropathic pain and or nociceptive pain. When we assess it, you have to assess it properly. And also, always the dressings are adherent to the wound. Okay, so when we change the old dressings from the wound, what happened? We used to do remove it because of the adherence. The adherence can cause that patients. If you are not soak the previous dressing well, there is a chance of pain. Okay, so always try to soak the own dressing well and then try to remove it. That way we can able to prevent pain. And coming to the malodor, so here there are a lot of necrotic tissues will be there, proliferative growth will be there. So because of that, there are a lot of necrotic tissues here. Anaerobic bacterial infection will be there. So we have to treat the patient's malodor well. Otherwise, that will be affecting the whole family. Because of the malodor, the patients, not the family members are not able to leave that patient the home, because a lot of smell will be there. This will be affecting the patient emotionally and socially also. So we have to try to prevent control the malodor and bleeding. Again, the dressings adherence to the wound. If you try to remove the without soaking, try to remove the old dressing from the wound, there is a chance of bleeding. And the another thing is the head and neck cancers. The blood tumors will be protrude there's a chance of protruding the major blood vessels. If these kind of situation, there you have to train the inspect the caregivers well, and we have to train them adequately, because if they that accident hemorrhage happen in their home, so how they can manage, you have to prepare the patient family well and exudates. So again, because of the proliferation, the blood internal the blood vessels will be dilated, and because of that, lot of exudates will be there. So, and itching will be there, because small nodules will be emerging to the sides of the wound. So that can cause the chemical reaction. That time the patients will itching, and also that oozing will be that exudates will be leak out the normal skin, and this will cause another problem, because itching again, this is the another cause of itching. Infestation with maggots, communication difficulties, because the patient is not able to especially head and neck cancers, they are not able to communicate their physical problems well. So what you can do is, if they are able to write down their problems, you can give a sheet of paper and ask them to write down their problems. So that way we can able to easily understand their problems. So otherwise, non-verbal, you can follow the non-verbal expressions. Okay, I'm coming to the psychological part, altered body image. This is very, very important. Just think about your pimple. So we have a small pimple in your face. What happened if the pimple size is enlarged? If we have a chance to see in a mirror, so how many times you go in front of mirror and check whether the size is increasing or any mark, whether there is any dark color happen. That kind of emotions will be inside our mind always. Okay, just imagine a fungating day by day, the wound size will be increasing, and this can cause the patient a lot of problems, malodor, bleeding, exudates. So these kind of things, the patients affect the patients emotionally and socially. Sexuality will be affecting. Sometimes delay will be there. The patient is even if they know that this is not going to heal well, but even then the patients says like my wound is healing well. That kind of that questions will be there. So these kind of denial will be there. So you don't take it as a challenge and make them understand this is not going to heal, this kind of wound is not going to heal. So gradually they will, you do one thing, you can listen their paper, listen their words and listen their emotions, and gradually they will understand the wounds is not going, not that healing well, and fear will be there, depression, anxiety will be there. So that problems will be increasing. That time they will be anxious. What is next? What is going to be happen next? That kind of thing will be there. If you control the symptoms well, they will feel better. Otherwise, they will be anxious about this kind of situation, and gradually they might go into depression too. Shame will be there, guilt will be there, these kind of things will be there. Coming to the social part, family isolation. Most of the time, if one person get this kind of illness in on family, the family members will choose the corner side room and keep the patient there. So they will not allow the patient to enter the kitchen or dining area and all. They always keep the patient like this only. So that will be affecting the patient emotionally. And social isolation, because relatives and friends are not willing to see these kind of patients because of the misconception. Social stigma will be there, fear of contagion, effects on family and effects on sexual relationship, especially marital disharmony. Nobody is willing to take a girl from this kind of family because of the hereditary factors, and this will be affecting the patient emotionally. Because of me, only my daughter is not getting a good proposal. That kind of things will be there. So these will be affecting the patient a lot, and interference coming to the spiritual part. Maybe because of that interference with the religious right, this kind of thing. I am getting this kind of problem, and because of my sin, God punished me like this. These kind of spiritual concerns will be there. So do one thing, you can do the proper assessment, listen individually. As if possible, you can do the individual assessment, because most of the time in front of the caregivers, they hide the truth. So if we ask anything in front of the relatives, they might be telling like, okay, she will be doing everything. So she is doing the dressing for me, this kind of thing. If you do the individual assessment to the patients will be telling the truth, like nobody is willing to take care of my wound. They will not allow me to enter the dining hall or dining that kitchen area. So they always keep me in the room only. So these kind of things will be there. And coming to the assessment part, wound location, wound appearance, surrounding skin, potential for complication. These all things we have to assess, because wound location is also important. Mobility important, easily always try to cover the wound properly, because I have seen a patient. I always remember that patient. He came with a long towel. He has a CA buccal mucosa patients, and he used to travel along that 8 hours journey. And when he come here, he used to bring a long towel. I asked him, why you're bringing this kind of long towel with you always. He's told me like, without this, I won't travel. So nobody is willing to sitting near to me. I asked him why, what happened. Then he told me like, if after the dressing, he used to take his towel and cover the whole face, clearly, and then he went back. Then he used to then tell me like, so if I cover like this, nobody's know I am having wound, and always the persons are just sitting near to me and travel. So if they have seen this kind of wound on my face, so nobody is willing to near sitting near to me. So that is very, very that the patient was crying that time. So because of my wound, why God punished me like this, sister? These kind of questions, the emotional questions will be were there. So I just listen his emotions and give a that talk to the patient and give a touch to the patient. That all done for that patient. I always remember his name and his emotions. Okay, so this is always try to cover the wound that clearly, because they can able to walk freely. And coming to the complication part, head and neck cancers, we have to prepare the patient that well, patient family well, because if there is a accidental hemorrhage, or maybe sometimes the tumor will be protrude the major blood vessels, that time they need to manage in their home. Okay, because of the death, because the bleeding can cause death. Okay, so because this is the major blood vessels can damage. So we have to prepare the family. Coming to the principles of management, palliation of symptoms, and try to relieve their symptoms. That is the only way to improve the quality of life of this patient. Okay, so try to reduce the pain, try to control the order and infection, try to minimize exudate, and try to minimize bleeding. These kind of things we do these kind of things, definitely we can able to improve the quality of life of the patient and the family. Holistic care, this patient need a total care and empowering the patient and family in own care. And coming to the criteria, the goal of care is to maintain or improve the quality of life through symptom control. Okay, we need a empathetic care. Always you have to think about the patient side. From the patient side, then only we can able to give some care to the patient. Provide a thorough bath before dressing. If possible, you can tell the patient to take a thorough bath, because these kind of wounds are fragile. If you apply more pressure on that area, it can sometimes bleeding will be there. Instead of that, you can, if they are able to take a good bath, all necrotic tissues will fall down. So these, if possible, you can tell them and ensure the patient is having a dose of analgesics before dressing. Always you have to think about the analgesics, and you have to do the pain assessment before dressing. Use normal saline for cleaning the wound. Select the dressing support based on the wound size and the exudate level. Coming to the pain management, if the patient is having deep pain, like a nociceptive pain, there your analgesics, maybe systemic analgesics will help to control the pain. But if the patient is having superficial pain, like a neuropathic pain, there your systemic pain relief sometimes not benefit. That time you can think about the local application like Sensocaine or Livinocaine. You can apply onto the wound and then wait for within 10 minutes the patients will get adequate some kind of anesthetic effect to the wound. That time the patient won't get on be experience any pain. Then you can do that. After that you can do the dressing. Coming to the malodor management, daily cleaning and dressing is one important part, and local metronidazole, same tab metronidazole, crushed and make it a powdered form and apply on the wound. Here we don't no need to mix with the white petroleum jelly, because lot of exudates will be there. Always the more the wound will be become wet only. So what you can do is you can apply metronidazole powder only, and also you can use injection metronidazole for irrigation, because lot of pocket formation inside the wound will be there. Your topical metronidazole will not be enough for going inside the pocket formation at all. Better you can use injection metronidazole for irrigation. That will help to control the infection. And systemic antibiotics, you can try a course of antibiotics, because superficially blood supply is not enough. This will not help much, but you can try one course of antibiotics for that, and that frequent change of dressings based on the wound size and exudate. Here also no hydrogen peroxide and betadine. This will not help anything to the wound. Especially if you apply hydrogen peroxide into the wound, this can cause irritation, and the patient may feel pain. And coming to the bleeding, always try to prevent bleeding. As I said earlier, the dressings are adherent to the wound. You have to soak well and then try to remove the wound, remove the dressing. So that way we can able to prevent. If bleeding there, you can apply local pressure on that area, and also you can apply sucralfate powder, and tranexamic acid also you can apply on topically. And if no, that kind of thing is not helped, then you can think about systemic ethamsalate and palliative radiotherapy. This will help to strengthen the size of the tumor. And dark color cloth, this is very, very important. You have to educate them, educate the caregivers. Always they have to keep a dark colored cotton clothes for wiping out the bloods, because if there is a accidental hemorrhage, or the tumor will be protruding the major blood vessels, that time the patient bleeding, the huge bleeding will be there. No, if they use the white colored clothes for wiping out the blood, what happened? The patient will be a panic, and the caregivers, the other relatives will be panic, and they will be anxious, and so lot of voice will be there. So these kind of things we can avoid if they are using dark color clothes. Okay, and role of cancer therapy, radiotherapy, cytotoxic chemotherapy, hormone therapy, and surgery. So these could can help to if the patient's health condition is good. This is the only thing is there is a chance of bleeding. So that time you can think about the radiotherapy and chemotherapy and hormone therapy. This will help to strengthen the size of the tumor. Okay, so that way we can able to that give some quality of life for a few months or life. After that, definitely the tumor size will again increase, and maybe there is a chance of bleeding will be there. So you have to make sure that the patient and family will understand about the patient's condition, and you have to prepare the family well. And surgery also, debulking surgery is also available, but the patient's health condition is good, then you can think about the debulk surgery also. So the next thing is maggots management. So how does maggots come? How does maggots come? Any answers? Housefly? Okay, very good. So the maggots is come from houseflies. Usually the houseflies are attracted to the infected wounds. When they touch the wound, they may lay eggs. Okay, within 8 to 12 hours, they come out with maggots. Okay, so always you have to prevent the maggots formation. Try to prevent maggot formation, because you have to give proper education to the patient and family. If they are not covered the wound properly, the housefly will lay the eggs, and then after that maggots will be there. If the maggots there, you can use turpentine oil, not pour directly. You can take turpentine into the gauze piece and keep close to the wound. That time the maggots will come out. Okay, so then you can take the maggots physically only. Okay, with the help of arthropods. And the important message I want to tell you all is, don't follow maggots. Okay, so if you follow maggots, what happened? If you go with your arthropods, they used to go inside. because a lot of pocket formation inside, they go inside and keep safe there. Then if you follow maggots, what happen? Your artery forces will damage the blood vessels. We don't know whether the maggots. Sometimes we think like, okay, you are the is there. So they when they go inside, we used to follow the maggots. So when you can leave the maggots there, then after that definitely they will, because of the turpentine oil smell, they will come out. That time you can then take it out. So that is the only way to remove maggots. Always try to prevent maggot formation. Thank you. If you have any questions, please.
Thank you, Sheeba. Really extensive, and that much is needed, okay, because people have to be aware and things. Any burning questions? I was just thinking, shall we go ahead with the case presentation and then come back?
Yes.
Any role for oral antibiotics in early stage?
Which one, ma'am?
They've just asked any role of antibiotics at the yes, your question is whether it's for pressure ulcer or is that right? Wait, just let me see. It was Dr. Meera or yes. Can you, what was it for pressure ulcer?
Yes, pressure ulcer, if they have any infection there, then you can think about the antibiotics. Otherwise, only cleaning with normal cell, like stage 2 pressure ulcer, only dermis layer will be breakdown. No, that infection and all, only clean wound will be there. There is that time no need of antibiotics. So you can think about cleaning and dressing. But if there is an infection there, then you can think about antibiotics.
Next one is how about culture and sensitivity? Again, there, no, culture and sensitivity will be based on how long it has been. First, you do everything and then still no response. Culture sensitivity of the wound. If it is a non-healing, might be helpful. And then should we make a choice of IV antibiotics and oral antibiotics fail with 2 weeks therapy? Again,
ma'am, if you are asking about fungating wound, that management, like malodor management, then we used to give metronidazole tablet, either topically and systematically also. You can give initially 3 times a day, and then you can think you can taper the tablet and BD and OD. Then you can stop 3 weeks, up to 3 weeks you can give. But the thing is, nausea and vomiting is one of the major side effects. Metronidazole and taste, loss of taste and all that kind of things.
See, metronidazole is very, very useful, and plenty of studies and things have proved that metronidazole, and we have also used a lot and seen very good response. I've seen in both like stage 3 type of pressure ulcer or a fungating wound also. In both places, metronidazole does work. And there was one more. Should we make a choice of IV antibiotics when oral antibiotics fail with 2 weeks therapy? That it's like it's not a must, I would say. Anything specific you want to add on, Sheeba?
Yeah, ma'am. So we usually what here do is we don't use any IV antibiotics. We used to apply topical antibiotics like metronidazole. As ma'am is mentioned earlier, this is a good drug for controlling anaerobic bacterial infection, metronidazole. So if the stage 4 pressure ulcer there, then the stage 3 or stage 4 pressure ulcer, they depends upon the wound condition. We think about the IV antibiotics.
And charcoal dressing, is it available in the
Yes, yes, market is available in the market, but the thing is quite expensive. Do one thing, you can make the charcoal dressings in your home also. You can teach the patient, the caregivers. They can take a coconut shell and burn it, and that charcoal is enough. They can take that charcoal and then they can make it a powdered form, and then in between the dressing pad, they can make it a layer like that. Then they can apply on the wound, not directly apply, not directly apply on the wound. They can make like a sandwich in between two dressing pads. They can give sprinkle the charcoal powder, or you can apply some white petroleum jelly first, and then you can apply charcoal powder on the top. That can that time the charcoal powder will stick to the white petroleum jelly, and again you can apply one more take one more amti pad and then apply on the wound. So that will help to reducing. That will help to reducing the stress.
Whatever has been told will be very, very useful, because many of them will be on financial strain. And so that will be one of the reasons why they're not getting and doing the dressing. So these type of things can be taught, and they are very useful and very effective. So that is something I would say one very important take home would be, if that could be taken, that will be very good. And one more question is there in the chat box.
The charcoal, charcoal is the good agent for controlling malodor. Studies say that is why we prefer charcoal. It will help to control the absorb the bad smell. Especially, you can keep 1 or 2 pieces of charcoal and keep it into the fridge.
Like malodor, it's been found to be very helpful. Just putting it under the bed, or they'll say just put it in one corner of the room. All forms, it does help. Does it help in wound healing? No.
Only control the bad smell.
That's it. I think we'll go ahead with the case presentation, Sheeba.
Yes, ma'am.
Sripriya, do you want to go ahead? Yes.
Hello, I am Dr. Shalu. I work as a medical officer in a PHC in Kerala. Okay, next. Patient named female Rathamani. She's a 42-year-old lady. Her diagnosis was non-healing ulcer left foot, diabetes mellitus, sepsis, and bipolar affective disorder. Next. She presented with the painless, non-healing wound left foot with a discoloration of skin around the big toe and swelling with redness of left leg below knee. History of present illness: a blister developed at the plantar aspect of left big toe, which ruptured itself after 2 days. She had no pain over that area, so she ignored the blister. A small ulcer developed in that area after 5 days. Then only her mother noticed it, taken her to the local hospital. At that time, blood investigation was done and found to be HB9 and serum creatine 2.1 and RBS 421 milligram per deciliter. So she was referred to district hospital nearby for better management. After admission, wound debridement done as gangrene developed in left big toe, amputation of left big toe done, and she was hospitalized for 23 days and discharged with blood sugar control, advised wound care from nearby hospital. She was diagnosed to have bipolar disease at the age of 21 years and is on regular medication for the same, risperidone, olanzapine, and oxcarbazepine. Then examination, her general examination findings almost normal except pallor and left leg pitting edema. Systemic examination is normal except CNS, as she is not cooperating for examination. On examination, ulcer involving left foot dorsum and plantar aspect with the left toe amputation. This is after the this picture is taken after the left big toe amputation. And now presently there is no foul smell or discharge from the wound at present. distal arteries pulsation are present. Next. Treatment and significant investigation. On admission, she was given IV antibiotics and other supportive treatment. Wound debridement done with a left picto amputation. Diabetes newly diagnosed, controlled with the insulin and OHA. After sepsis control, serum creatinine decreased to 1.4. She was given psychiatric consultation also, as she was not on any regular follow-up. Medication, psychosocial aspects. Her father died 15 years ago. Mother is 60-year-old and taking care of her. She is unmarried because of her psychiatric illness. She has an elder sister who is married and living separately. No regular monthly income for the family. Mother is getting old age government pension and she is not going for a regular monthly job as the patient is alone at home. Her mother is participating in Mahatma Gandhi National Rural Employment Guarantee Act, which offers a 100 days job for a family member in their neighborhood. Mother is also worried about her daughter's safety and future. Mother is also diabetic and hypertensive and has hypothyroidism on treatment. Both mother and patient is getting their regular medications from the near PHC. Now, palliative care team is taking care of wound management at home as she can afford coming to hospital daily. Now she is currently on risperidone 2 mg OD, tab olanzapine 5 mg HS, oxcarbazepine 450 in the morning and 600 in the night, then metformin 500 BD, tab glimepiride 2 mg BD, human mixed insulin 22 in the morning and 10 in the night, and tab vitamin C and megahil ointment for local application. Next. Main concern is patient wound will take time to heal fully. Till that, her mother won't be able to go outside for any job. As the family income is very less, they can't afford nutritious food, which is required for speedy wound healing. Currently, they rely on government ration per month for groceries. Her sister is not financially able to help them too. As the patient is on psychiatric medication, her self-hygiene is very low. Next. Summary, she's a 42-year-old female unmarried patient with bipolar disorder, newly diagnosed to have diabetes, presented with a non-healing ulcer for last 1 month, which needed 3 weeks hospitalization and wound debridement involving left big toe amputation. Currently, she is at home with a palliative home care team giving wound dressing and other supporting treatment. Next. Discussion points. Do this patient need palliative care? What are the problems faced by the patient? What all can be done for this patient and her mother? Actually, I took this case when this course started. So actually, this is not a palliative patient. She is not terminally ill, but her present situation needs our palliative home care management because she can come to her hospital for daily dressing. So the palliative home care team, which is assigned to our PHC, they go for wound dressing and other supportive management for the patient. Ma'am.
Thank you, Dr. Shalu, for presenting. See, like she has got multiple issues. Okay, yes. You said not life-threatening, but these are all long-sustained health issues which need to be taken care of. And let's go from there. Like, what are the problems? Like, especially from what we have heard today. What are the problems faced by the patient? This patient has such, if you take. Like anyone in all can participate in the chat or type or whatever. Either way, unmute and speak or type in the chat.
Ma'am, these patients' wound will take time for healing. They are getting only ration from the government, like rice and only grains. They don't get any vegetables or fruits or any other proteins from that store. So we somehow managed to arrange a sponsor for once monthly supply of these vegetables and fruits in a little bit manner. And we also help them to get that from other people also, like a donation, etc.
Some
So,
community participation.
yeah,
You
yeah.
know,
As this patient is 42-year-old, she's little stubborn and she doesn't have any or hygienic day-to-day habits, no.
that can be
So
taught.
it's
Like I
very,
know psychological
yeah,
issues are there.
yeah. And her
Some
mother is as old. She is also not very much can taken care of this patient because she is also an elderly patient.
That's all. So ideally, the patient has to have some counseling or something. The mother looking after her itself is a big blessing for the daughter. So if some counseling could be arranged for her, so that she's aware of what is the situation, and then something has been typed. I'm just trying to read that also. Financial support and occasional training for the mother to earn from home. See, those can be done what is possible, and then patient also to be counseled and trained to take care of herself. Exactly. So both patient to concentrate more on the patient first, and then to help the mother in all possible ways, so that we have to be a little bit realistic and practical also in all these things. So ideally, what we can do can be helped in, so to see what is the pressing issue, talking to her, giving some couple of counseling sessions for the patient to see how it could be managed. Sheeba, whatever you want to add on?
Like to hear from the participants, others, please
they-
respond. Yeah,
that's
any
what
other,
the chat was, what
yeah.
I read only was in the chat.
Madam, one more doubt. The metronidazole tab formulations available are for only oral injection, and it will be metabolized in liver, and then only active products will work as an antibiotic. So how does it will be helpful in local application when the tablet is crushed and applied?
Systemic absorption will take place when it is crushed also.
Okay, ma'am. So is it superior whether that metronidazole gel is available or it's a crushed tablet?
See, between the gel and tablet, it is said the gel has less. If you see the gel, the percentage of metronidazole is less in the gel. So that is why we prefer the tablet.
Okay, ma'am.
Powder
And
making.
yeah.
Go ahead,
And
Sheeba.
another thing is the metronidazole, the ointment is quite expensive, little bit expensive.
Yes.
Okay.
Expensive, and concentration is also less.
Yes.
Anything else, Sheeba, you wanted to say?
Yeah, so no, ma'am, you have add all the points. I think this patient need a good community support, and also you can think about the vocational rehabilitation also, because the mother is not able to going for work, and you can then because of his her doctor, she has some the psychiatric
Psychological
problem
issues.
also, the psychiatric
Psychiatry
problems,
and,
yeah,
psychiatry and
problem.
psychological both.
Yeah, so what you can do is you can think about some occasional rehabilitation, and make sure that there is some kind of income from that, and that kind of things, if you do it, then we can able to improve the quality of life of the patient. Definitely. What about the blood sugar level, ma'am? This patient is controlled, or
Now it's
How is
controlled with the insulin and OHA.
okay?
And her
So
mother is insulin taker.
okay, okay. So you can always you can try to if whenever possible, try to cure. Here is a curative wound, so you can try to think about the curative part first, and try to like diabetic. If you have if you need to do the diabetic management, you can do that part, and if you if you want to show the surgeon to the wound, definitely you can include the surgeon into this patient care, and no need to send the patient to the surgeon. At least you can make a call to the surgeon and ask them. So this kind of wound is there. So this patient is having this kind of fitness. We can't. We are not able to send the patient to you. Can you suggest something? These kind of telephonic conversation also can help for some kind of suggestions you can give to the patients. Maybe a surgeon is a good.
Yes, see, that's what. With this patient, no regular dressing, and then maybe finally she could benefit from a skin graft or something, which will take away and help her also. It all depends on regular follow-up, wound care, and then you get her diabetes under control, and then follow it up with a surgeon, and then see furthermore what can be done, and then from other total care is psychological counseling and things, and encouraging her with vocational training. She herself may get better. She may have a better quality of life, and her other issues may come down. So totally in total management with the help of community and whatever support is possible, worth giving it a try, and then in couple of consultations to make sure that she participates.
Yeah.
Encourage her to participate and improve.
Teamwork is very, very important here. We need to do it with good teamwork to better care of this patient and family.
Find out what are the go in, sit with them and see and find out what are the issues.
Yeah. Anybody like to add anything?
That's also maybe we could come out of this presentation so that like anybody wants to add on, ask or whatever.
So, and I read on article like topical application of insulin is good to heal the diabetico. I read one article regarding that. I think you can try a period of time the topical application of insulin. I don't know how many of you have any experience. Do you have any experience? Anybody? This group, this topical application of insulin. No. Okay.
We have cost our time also.
Yes.
So over to you, Sri Priya.
Thank you, Sister Sheeba. I know personally, since I work very closely with you, your days are always tiring. A lot of works to be done in and around Pallium. So thank you so much. You found out time to interact with this batch. And we do definitely look forward to more enlightening sessions from you in future. Thank you everyone for joining in. And with the promise that we will meet again in the next session with a different topic and yet an eminent faculty. This is Ripriya, along with Sister Sheeba and Dr. Radha, signing off from the Tips Eco Hub. Till the time we see again, take care everyone, stay safe, be happy, bye-bye.
Thank you all. Thank you, ma'am.
Thank you. Thank you.